Hi everybody, Dr. Britt Talley Daniel MD, and I'm a neurologist and headache doctor. Today I'll be YouTubing about the subject of non-narcotic treatment of migraine in the emergency room. Migraine is a common problem affecting 12% of all persons, as 25% of women and 6% of men have it. It's a very disabling neurological condition, so many persons with bad migraine attacks end up in the emergency room. In years past, many of these migraine patients were given IV opioid treatment, which was not that successful for analgesic or pain killing, and was very sedating. Usually in the emergency room, the patient would have a brief general medical exam, including vital signs, and sometimes general labs such as chemistries and blood counts, and sometimes a CAT scan of the brain would be performed. Most of these patients would be referred to a headache neurologist for an outpatient visit after their ER visit. However, in the days of COVID, that may now be a tele-neurology visit. The problem would be that the opioid narcotic wouldn't help their presenting headache very much, and many patients would have to return to the emergency room after a day or so because of continued pain and disability. So that ER doctors are always looking for other drug treatments for acute therapy of migraine. This article is about the successful use of non-narcotic drugs in the ER setting. IV prochlorperazine plus diphenylhydramamine are better than opioid treatment for migraine in the emergency room. So the conclusion of a study that was done recently is that IV hydromorphone is substantially less effective than IV prochlorperazine in the treatment of acute migraine and should be used as first-line therapy. Friedman et al. In the Neurology article written in 2017 entitled Randomized Study of IV prochlorperazine plus diphenylhydramamine versus IV hydromorphone for migraine. The objective was to determine outcomes among patients with migraine in the emergency department who received IV hydromorphone versus IV prochlorperazine. Had a trial there which was halted after 127 patients, and the conclusion was that IV hydromorphone was substantially less effective than IV prochlorperazine for treatment of acute migraine in the ER, and it should not be used as first-line therapy. This study provides Class 1 evidence that for patients in the emergency department with migraine, IV prochlorperazine plus diphenylhydramamine is superior to IV hydromorphone. An editorial comment was made by the American Academy of Neurology in that article stating, one of the many studies showing certain safe non-narcotic drugs that work better than opioids in the emergency room. So drugs to consider on ER discharge. Butalbital as a barbiturate has been banned all over the world in every country except the United States and Canada. It's notorious for causing medication-induced headache. Is not a good oral drug to keep patients after an ER visit for headache. If the ER doctor thinks the patient has migraine, he might write a small number, like number 10, his favorite triptan, sumatriptan or something like that, advising the patient to treat early and only use 2 treatment days a week until he sees the neurologist. Also, DHE or dihydroergotamine as migraine nasal spray or timolol eye drops may be a reasonable substitute in this situation. Hopefully this study will impact emergency room practice to provide better relief for migraine patients who present to the emergency room. So this is the end of my talk on this subject today, kind of a short talk on non-narcotic treatment of migraine in the emergency room. Please check with me on YouTube for other headache talks I have there. Click subscribe down there so we can follow each other. And thanks for listening, and I will see you on the next talk.